Hello, I'm Bob Falcone, CEO of the Columbus Medical Association and its affiliates. Today, I have the pleasure of speaking with Dr. Andrew Thomas. Andy is Chief Clinical Officer of the Ohio State University Wexner Medical Center, and he's the governor's Zone 2 lead for our pandemic response for our region. I'm also going to be speaking with Dr. James Borchers, who's head of the Sports Medicine Fellowship at the Ohio State University and the lead team physician for Ohio State University Athletics. Gentlemen, welcome.
Good
Hi,
morning.
Bob. Thanks for having us.
Andy, can we start with just a quick update on where we are with Zone 2? And it looks to me from looking at the recent data, including the heat map, that our region's in good shape.
Yeah, so far, I think the last few weeks have looked very, very positive. We've come down from a high in late August to a much, much better level. We've plateaued over the last 4 or 5 days with a slight increase, but nothing near where we were back in August. So I think overall, we've come through Labor Day, and we're now enough weeks out to know that we're not seeing a huge spike in hospitalized cases. And certainly when you look at the heat map, as you said, there's a lot more orange in central Ohio than there was 5 or 6 weeks ago. So I think all those trends are positive. I think the face mask rules that went into place earlier in the summer have certainly helped. And I think as people have realized the importance of keeping their local school open, their local teams playing, just kind of the local activities as we go into the fall, if we can keep things under control, that's keeps a lot more things open. So I think people are really learning how to live with this pandemic. None of us are thrilled with some of the things we need to do at the same time. I think people realize it's really the price of keeping a local school or business open is compliance with some of the public health guidelines.
Thanks, Andy. And as I understand it, Ohio State, its students, faculty, and staff are rocking. Your numbers are extremely low. Very impressive.
They have improved substantially in the last 3 weeks. When students first arrived, we did testing for those in dorms, and the percent positive was very, very low. Within 10 days to 2 weeks of starting school, there was a spike in cases. That spike was actually more off campus than on campus. So we think certainly in the classroom setting is very, very safe. The dorm setting, because there is some oversight with RAs, there's certainly peer pressure of people who live on your hallway, et cetera. The rate is now less than 1/4 what it was a month ago. And then the off-campus rate is still higher than the on-campus rate when you think about Greek life and you think about large apartments or houses that have 4 to 6 people living in them together. The rate is higher off-campus for students that we're testing, but it has also come down and is about 1/4 what it was at the end of August. So we think the students are really, once again, the behavior change, the way they've done college, quote unquote, in the past is very different this year. But I think they're really understanding the importance to keep the semester open.
I think Andy and Jim and the rest of your team at the Ohio State University, from the president down to the fans, really went to bat to get our football season back on track. We probably have a number of people viewing this video that are still a little confused. Jim, can you give us a brief summary of why the season was canceled and why it's back on?
Yeah, well, I think first and foremost, the decision was to postpone, not to cancel. And I think it was appropriate at the time. There were a lot of questions, a lot of uncertainties. And when the chancellors and presidents met on August 11th, I think they did not feel comfortable, as Dr. Thomas mentioned, knowing what was going to happen when students returned to campus, what the resources would look like, what testing would look like, and the ability to properly evaluate and ensure safety for athletes. And so, as often happens when we have these questions, it's appropriate to take a pause. It's appropriate to get people together to assimilate evidence and information and continue to explore that and then find a path forward. And I think that was the process that happened for the Big Ten Conference. And as we reconvened, as people were collecting data, as people were able to look at various options that became available in many different areas, it became clear that there was a way to get to the starting line and put a path forward for beginning a return to competition for athletics. So I think, as frustrating as it may be and the process may seem, it actually played out appropriately. And I think the Big Ten Conference ended up in a really good space when they made the decision with the presidents and chancellors to begin return to competition.
And Jim, you were a co-author on a very elegant study published in JAMA looking at COVID-19 athletes, COVID-19 positive college athletes. and the risk of myocarditis, or at least the incidence of myocarditis. Can you give us a brief summary of that?
Yeah, so as you know, we've studied our athletes here that have had COVID-19 with a protocol that includes labs, biomarkers, EKGs, echocardiograms, and cardiac MRI, in an attempt to help to characterize the risk for younger asymptomatic populations with the cardiac involvement of this virus, as we know, is very different than many of the coronaviruses and other viruses that we've seen. And certainly we need to learn from that. The Big Ten now has a registry where we're studying that across the Big Ten conference. And it's not meant to alarm people. It's meant to inform people and to help us to find answers as to who may be at risk. And I think part of the issue is that we don't have a good way to identify that, even with some of our common things that we do in histories and physicals and labs, and even looking at EKGs and studying that and understanding what does maybe signal someone needs a more substantial workup. So that work is ongoing. It was important for us to get that first subset of subjects published. We now know that throughout the Big Ten Conference, there are hundreds of athletes that have had similar workups, and that cardiac registry, we believe, will be a great way for our 14 world-class institutions to inform on this area and to provide some guidance to our clinicians who are asking lots of questions about how to move forward. So I'm very proud to be a small part of an amazing group here at Ohio State in cardiology and imaging and medicine that has put forth this effort and really led in this area.
And I think even though your study was smaller, you showed that about 15% of the people you studied had myocarditis, and 2 of those were asymptomatic. Is that relevant to our ongoing discussion?
Well, I think it is relevant because we know that at least looking at myocarditis in athletes, the prevalence is much smaller than that from what we know and what we study. I think we have to be a little careful. We're doing some advanced imaging that hasn't been done in the past, and certainly what we're identifying meets criteria for myocarditis. What is not quite known yet is the clinical implications of those findings. But we do know that unfortunately, myocarditis is a cause of sudden cardiac death in athletes, and it's not a cause of sudden cardiac death in athletes that show significant clinical symptoms. Those athletes are usually sick; they're not exercising. It's the athlete that is mildly symptomatic or clinically asymptomatic that may be at risk. And so we wanted to make certain with what we were learning about this virus that we're doing our due diligence to identify those athletes and informing on that. And so it is concerning, but it's something that we need to continue to look at. And as you mentioned, the 15%, I think it was right around 14.7% specifically. We need a much larger sample size, obviously, to further define that prevalence. But it is something that we felt was significant enough that it needed to be published, and JAMA certainly felt the same way.
Yeah, Jim, I think as a primary care doc, and we've talked about this a lot, obviously, but as for the primary care docs that are listening on the line, when they have a 45-year-old patient who's a normal weekend jogger, bike rider who calls and says, "Hey, I had COVID. I read this article in the Dispatch about this study. What do I need?" I know I've had this discussion with some of my patients, just talking about, certainly scaling up exercise over time, looking for symptoms of exercise decompensation and shortness of breath that is far below their normal exercise tolerance. But any thoughts for the average primary care doc on how to counsel patients on this?
Yeah, I think you're exactly right, Andy. I think what we've said, the most important thing that's come out of this is that anyone who's COVID positive should have a discussion with their healthcare provider before they go back to exercise. I think to discuss what their clinical course was like. We certainly know those patients that have been febrile for a longer period of time or have had more significant symptoms are at an increased risk for cardiac involvement. And I think, as you mentioned, then having appropriate counseling for how to appropriately go back to exercise and what the signs and symptoms are that they need to watch for, and then getting an appropriate workup in a COVID positive patient if they're not feeling appropriate. I think, and that's especially in the younger athlete population, where we have seen a lot of athletes that you thought, oh, they're just out of shape because they've been sick or they're not getting back appropriately. We probably need to be more vigilant with those folks. But as you mentioned, even for the recreational athlete, Unfortunately, there have been cases of sudden cardiac death, even post-COVID, in those in athletes of that age group. And so, or a discussion with their healthcare provider. I just think it's being connected is really important, and not just taking it on, and saying, oh, well, I'm feeling better, so I'm going to go do X, Y, and Z, I think is really important. And I think that's the most important step in all of this.
And I know the guidelines are still evolving, but the way I see it as a primary care doc is, any of those patients I see in the office, I get an EKG on, just that, it's probably not going to find something, but if it finds something, that's important. If they do start a scaled up exercise program and they're having more symptoms, certainly getting an echo at a minimum, probably having them see a cardiologist, and then probably that decision on cardiac MRI is really up here for the cardiologist to make. But I think that if the echo is normal, it's hard. I'm hard pressed to order a cardiac MRI, but I want the cardiologist to determine that. Does that kind of seem to make sense?
Yeah, I think we have recommended that, if you look at most of the guidelines that are out there, you're stating exactly what they state. I agree. I think anyone you see in the office who might be returning to exercise, I think getting a baseline ECG is an excellent start. I think you're right. If they become symptomatic, or if they're symptomatic with exercise, if they're a recreational athlete, starting with an echocardiogram and having them see a cardiologist to make that decision about cardiac MRI. I do think if you have a more competitive athlete, or an athlete who is at a level where they're competing in significant athletics and training significantly, there may be a little bit more, as is suggested by many groups, a little more aggressive approach if they're symptomatic with their activities, to going to cardiac MRI sooner. Because those athletes are the ones usually that are at risk, that'll push through their symptoms a little bit more. So I think you're right for most of the people that you're going to see that are returning to regular exercise. That's an excellent approach.
Andy, I know that one of the caveats for restarting football season is to begin testing every athlete, the coaches and the staff every day. How are you doing that?
Well, actually, I'll turn that back to Jim. I will tell you, similar to what we've done with the students on campus that are not athletes, one of the principles was that we did not want to negatively impact the availability to get tests in the local region, either here and certainly in Central Ohio. But when you think about the other 13 campuses of the Big Ten, we don't want to negatively impact the other citizens that live in that area by taking up local hospital testing. So Jim's actually led the effort with the Big Ten to determine the right way to do that testing, and I'll turn things over to him.
Thanks, Andy. And what Dr. Thomas mentioned was one of the guiding principles for our medical subcommittee, was not to impact the healthcare of the local communities or university community. What we looked at was, the difference between surveillance testing, screening, and then diagnostic testing, and certainly putting a surveillance strategy in place, which means using a test where we can test frequently, get immediate results, isolate anyone that might be positive, and then do confirmatory testing. Which is a little different than what some of the strategies have been for some of the athletic teams that have been out there. And so we will be testing our athletes on a daily basis with a rapid point of care antigen test, and using that test then to identify and remove anyone that may be positive in the population. We'll be doing confirmatory PCR testing then to confirm those results, and then treating those athletes that are confirmed COVID positive as they should be. We'll also be doing quality assurance with PCR on our negative antigen testing to make certain that antigen testing is doing what it should be doing, which is appropriately identifying people as either presumptively positive or negative. But we felt much more confident as we moved through the weeks from the initial postponement on some of the data that was shared with us on some of the antigen testing in much larger groups of people around sensitivity and specificity, and believe that we have again, just emphasize this, a way to get to the starting line so that we can start this program, monitor it, but again, being able to make certain that we're not negatively impacting the community, but identifying athletes quickly, removing them from the population, isolating them before they're infectious to anyone else. And so that was critical to our plan moving forward.
Yeah, one of the key principles, Bob, was to have a clean field on game day.
Right.
And I think this approach, both in terms of routine testing of the core individuals daily, and then I believe Jim's is still twice a week for kind of the other associated folks with the team, some of the team staff and other things, will really guarantee when you get to Saturday that there's a clean field.
Is this a saliva test?
No, so the antigen test is a nasal swab. So it's a nasal swab and then a rapid point of care 15-minute result immediately. Doesn't require us, sending the test out to a lab. And then the confirmatory testing is nasal pharyngeal swab for PCR testing.
And if you have an asymptomatic athlete and the test comes back negative, um, I assume we consider them negative and stop there. Is that right?
Well, if we're talking about the antigen testing, they'll be tested daily. So yeah, they'd be allowed to move forward. There is obviously with any surveillance testing and even with antigen testing, the remote possibility of false positives if the test is done appropriately. And so that's the reason for confirmatory testing, but we will follow the results of the PCR testing as our gold standard. So it is possible that we hope, obviously on a rare basis, there may be a false presumptive positive that an athlete would be able to return if they are confirmed negative.
Yeah.
No different than what we saw with the governor when he had his issue back earlier in the summer.
But again, a false positive test is less of an issue in this setting than a false negative.
Correct.
That's
And
correct. Yeah, that's
and
correct, because we're isolating those people that even as false positive, and that's out of an abundance of caution and safety, which is what our planning needed to be.
Right.
The willingness, though, or the reason it's okay to have some false negatives, Bob, is with serial testing daily. If you have someone who's on that upswing of
Right.
viral load, you're going to catch them tomorrow if you don't catch them today. It's not like they're going to be negative the whole course. You just might miss them early on, where a really sensitive PCR might catch it. But if there's at such low level before they do turn positive on the antigen, that they're probably not even that infectious. Certainly compared to not testing, it's no different risk. But this does allow us to spread the testing over a lot more people, do it a lot more routinely and a lot quicker results. So all those are the trade-offs for a slightly increased number of false positives or false negatives. I'm sorry.
That's still a lot of testing. How is it impacting your capacity at the university?
It's actually
It's not
not.
impacting our.
Yeah, at
No,
all.
it's not impacting our capacity at all because we're not actually relying at this point on antigen testing. So these are tests that the Big Ten has purchased from the vendor directly. So it's not. Obviously, there'll be a handful of extra PCR tests to do, but to be honest, we've been testing the athletes anyway. So in many ways, this is less testing than we've been doing from a PCR perspective on these same athletes since early in the summer.
Jim, it's probably one of the more difficult questions. When do you let a COVID positive athlete play again?
Well, the Big Ten has defined that pretty clearly. That they have to go through. If it's an asymptomatic athlete, then they will follow CDC guidelines, obviously, and have to isolate for 10 days. If it's a symptomatic athlete, we'll follow CDC guidelines, where at the conclusion, during that 10 days, they have to be afebrile without medication for at least 24 hours and have all significant signs and symptoms improved before they would be allowed to break their isolation. And then we have a protocol for cardiac clearance through the Big Ten Conference that has to be completed no earlier than 14 days after resolution of symptoms or the COVID positive testing. And then at that point, if they have cardiac clearance, then the medical team will transition the athlete back to activity during a 7-day period. And the earliest an athlete can return to competition is 21 days status post COVID positive. And we believe that helps us to follow all the required protocols and return to activity evaluation that would be needed for someone to return. So again, the message is prevention. Athletes, we don't want them to become infected, and we do have a procedural approach, to guide them back to activity.
When we talk about this in college athletics, it sounds like it's fairly well hammered out. Do you have any advice for the high school coaches and team physicians out there that are watching?
Well, I think what I mentioned even when we spoke with the governor is understanding your local situation, and I think one of the things we talked about in the Big Ten was really drilling down into your individual community and your individual situation at your school, and even further into your team. Obviously, making certain you're following all the precautionary steps that need to be taken for prevention. I think that it's been interesting to see so far the return to school and return to sport and school-aged athletes. We have not at least seen a lot of reported increased number of cases. That I don't know that doesn't mean there aren't some out there. But I think that vigilance is the key, and then making certain you're following guidelines at this point is the key as well. And then quickly, obviously, removing, isolating, quarantining, and doing things we can to prevent infection spread. And I think that's going to be the most important thing as we continue to move forward.
Yeah, Bob, I know for our children's school, they put processes in place where before there's any game, the two athletic directors talk that morning, make sure that, I'm thinking about my niece's soccer team, and make sure that they've been following all the protocols. There's no positives. I know they've had one game canceled because the other team had two positive girls on the team and two others that were quarantined. And they decided, let's just pause. We can play this game later in the fall. So I'm hopeful that at the high school level, there's constructive discussions going on as well between coaches and ADs about needing to limit unnecessary exposure of folks when there's positives on the team.
One
So
of the things,
sorry,
Bob,
go
one of the comments I wanted to make was one of the things we're seeing as well, and I think this is a reassuring thing for athletics in general, is that there really have not been documented cases of spread within the athletic event itself. Almost all the documented cases that we're seeing amongst athletes are in residential situations, social situations, and in fact, in the Big Ten, we could not find a case in the conference from this summer where someone had actually been exposed, quarantined, and all the athletes were being tested during their quarantine where they became positive when they were exposed to an athlete who was positive potentially in an athletics situation. So we think that the actual risk of spread in most athletic activities, and certainly in the fall when they're outdoors, which is where we've seen most of this, is very minimal. And that is something that's reassuring, I think, and at least in anecdotal sense, gives us some reassurance about athletics and what's going on.
When we have a high school athlete, a competitive high school athlete that is COVID positive but asymptomatic, do they go through the same cardiac algorithm as far as workup before they go back to sports?
I think as was mentioned here, I think they need to be appropriately evaluated by their healthcare provider. I think that they need to talk through what the appropriate evaluation is. There are guidelines out there to help suggest that, but as Dr. Thomas mentioned earlier, I think having the ability to initiate workup quickly if there's any concern. Really, most of the guidelines say that if there were any symptoms at all, at least an ECG is indicated, and many people have then gone forward with an echocardiogram in a competitive athlete. And if there's any exercise intolerance, then referring to a cardiologist, as was mentioned, for any further sort of workup. So if someone is completely asymptomatic through their course, was never febrile, has no symptoms, and meets with their healthcare provider, and they think that it's reasonable to start back to exercise, I think they just need to be monitored appropriately, so that if there are issues with exercise, they're reevaluated quickly.
Yeah, that's exactly what's in the state guidelines, Bob, is just that every athlete from a high school sports perspective should get in touch with their doctor before they start. And then this would be what we would recommend those doctors do.
That's very helpful. So I think this discussion's been very helpful. As I understand it, the Big Ten didn't change its mind. It just simply evolved with the evolving opportunity to better test and some solid guidance around preventative measures, which are very important. And then an understanding that myocarditis is probably not as prevalent in the competitive athlete as we thought. Finally, that we have protocols for managing COVID positive athletes that sound to me very safe and logical. Does that cover it?
Well, Bob, I think the other thing that's important to note is the leadership that Jim Borchers showed in all of this. He chaired the committee for the Big Ten medical directors and has really become a national leader on this topic and has just done amazing work. And we couldn't be any more proud of him if we tried. He's just been a great leader and really brought along the presidents and the chancellors to really understand that as the science evolves, as the testing evolves, there was a way to do this safely. And we just completely applaud him in his work. He's a big part of why we're going to see football in Big Ten stadiums in the fall.
Well, Jim,
Thanks,
on
Andy.
behalf of a whole lot of Buckeyes, thank you.
Thank you. I appreciate that. It's been a privilege to work with that group and to do this work. So I appreciate that.
As a former OSU football player yourself, I know this has a special place in your heart. So That's terrific job, Jim.
I'll be happy. I'll be happy on the 24th of October if we're seeing football in the stadium, even if it's most people are watching on TV. You're right.
Understood.
Well, thank you, gentlemen. On behalf of Andrew Thomas and James Borchers, this is Bob Falcone for the CMA. Till next time.